Welcome and thank you for joining today's webinar. This is the third and final session of this webinar session on child protection and health integration during major disease outbreaks, hosted by the READY Initiative, just funded by the Bureau of Humanitarian Assistance. We are happy to provide live interpretation into French and Arabic for today's webinar. If you're interested in listening to the session in one of these languages, please click the globe icon that says interpretation at the bottom of your Zoom screen and select your desired language. During this webinar, we encourage you to ask questions using the Q&A function, and access to today's recording will be available on the READY website. It is now my pleasure to turn it over to Sarah Collis-Kerr, the lead technical advisor for the READY Initiative. Sarah.
Thanks, Vasika, and welcome everyone, and thanks again for taking the time out of your busy schedules to participate in READY's third webinar in this three-part series, so the final one, focusing on communicating with children during infectious disease outbreaks. So just very quickly about READY, for those of you that don't know, the READY initiative has been in existence since 2018, and it's funded by the Bureau for Humanitarian Assistance. We're a consortium of partners with Save the Children as the lead, but we also work with Johns Hopkins University, Centre for Humanitarian Health, the Centre for Communication Programmes, UK Med, and the Humanitarian Leadership Academy. And our overall goal is that for NGOs to have the tools, knowledge, and skills to support crisis-affected communities and local authorities to effectively respond to major epidemics and pandemics in humanitarian settings. And we're doing this on a global level and helping to produce a lot of the needed guidance, tools, and trainings. So you can access a little bit more through the link in the chat now. So to start this very, very exciting webinar that we've been wanting to do for some time. So the READY initiative is in quite a unique position, and we understand and hear from many groups and individuals about the gaps they're experiencing when responding to outbreaks. And one that we're hearing time and time again is this one around communicating with children, and specifically child-centered risk communication, community engagement. Whether it's lack of materials or lack of expertise, or overlooking the importance of child-centered RCCE altogether. And so I just wanted to start this webinar by reminding us about one of the reasons, and there's many more, on why communicating with children is so important. And here are some key findings from Save the Children's global research, which was capturing children's views on the COVID-19 pandemic and its impact on children. So this study consulted over 17,000 parents and caregivers and over 8,000 children, and 74% reported feeling more worried than before the pandemic, and 59% feeling sadder. Less than 46% said they were felt listened to, and when talking with their family about COVID-19, only 1/3 said their opinion was asked. There was also a significant relationship found between children feeling more worried and those who felt that their parents and caregivers did not talk to them about COVID-19. So you can read more about this report, and the link will now be in the chat for you to access. But I think we can all agree that these findings are likely to be very similar in other major disease outbreaks, whether it's cholera, Ebola, or now the Marburg outbreak too. And that we need to prioritise access to accurate and child-centred information, not solely reliant on parents and caregivers. And that hopefully by including children in programme design, monitoring, and decision-making for outbreaks, we can improve their overall well-being and coping abilities throughout these major events. And lastly, we cannot really achieve effective and quality outbreak programming, including RCCE, if we do not include children, seeing as they're such a vital and large part of these populations, especially in humanitarian settings. So I would like to now introduce our panel for today's webinar. So I'm very pleased to introduce first Stephanie Bradish, who is the Regional Risk Communication, Community Engagement and Humanitarian Accountability Advisor for Save the Children. Then we have ReaDy's Nidhi Kapoor, who's a child protection specialist and independent consultant. Nidhi is currently supporting many activities within ReaDy to improve collaboration between the health and child protection sector in outbreaks. We have Jean Seander, who is our child protection lead for ReaDy, and she's also the humanitarian child protection advisor in the Global Centre for Humanitarian Technical Team for Save the Children. And she'll be trying to answer some of your questions from behind the scene, typing them in the Q&A function. Then we have Rui Mutemba, who's the communications coordinator for Save the Children International in Mozambique. We have Aloysius Magnot, who's the interim country focal point for school health and nutrition in Save the Children Uganda. And then we're also joined by Henk van Beers, who's the global lead for child participation for Save the Children. So what will be in our webinar today? So first, we're going to explain what risk communication community engagement is and linking this to key terms and concepts related to RCCE. Then we'll talk about key considerations for child-centered RCCE in outbreaks, and then followed by 2 excellent case studies from Mozambique and Uganda, our usual time for question and answers. But please don't hesitate to put your questions in the Q&A functions as we go through, and our team can begin answering them there now. So without further ado, I'll hand over to my colleague, Steph. Steph, over to you.
Thanks so much, Sarah. So as we promised, we would go over the basics of RCCE. So risk communication and community engagement, which I will now and my colleagues will shorten to RCCE, is an approach used in public health emergencies and infectious disease outbreaks. The approach was developed and defined based on the learnings from the West Africa Ebola response in 2014. Proving to be an effective method at slowing and ending outbreaks, it is recognized by the World Health Organization as a key pillar for quality response. RCCE really focuses on putting people at the center of the response. Its main objective is for individuals to have relevant, actionable, and life-saving information at the right time to raise awareness on risks and promote behaviors to protect themselves, their families, and communities. Impact from this approach comes from its ability to complement existing knowledge, resources, and capacities at the community level. Also comes from working with communities as key response partners, not passive bystanders, and its ability to evolve alongside shifting information needs throughout the different phases of the outbreak. RCCE is an evidence-based approach, and it draws on a combination of health, epidemiological, and social science data to identify and address the different drivers of behaviors and norms related to the outbreak through communication and community engagement activities. Some examples of the activities that fall under the umbrella of RCCE are public health and response messaging through mass media, print, digital, and interpersonal channels, rumor tracking, social listening, and community feedback mechanisms, demonstrations of key infection prevention, control, and treatment measures, working with healthcare providers, influencers, survivors, and their families to provide testimonials, social mobilization and community-led action, and co-design of response strategies and RCCE approaches with community groups. On the right-hand side of the slide, you can see an example of materials used by the Social Mobilization and Action Consortium in Sierra Leone during the 2014 Ebola outbreak. As the disease spread, so did social stigma, which led to individuals not seeking care, which resulted in difficulties in treating and tracking the disease. To address this, a communication campaign featuring Ebola heroes, like Al Hassan, was started, with the important contributions of healthcare workers, law enforcement, and survivors highlighted to combat the stigma. Perfect. Now we're moving on to key terms and concepts. So in the space around RCCE, there's a lot of terms. They are vast and often overlapping, as they all to some degree reflect work with communities with the objective of supporting positive social and behavior change. The context, objective, scope, and sometimes even the organization will dictate what we use. To clarify, I just wanted to quickly go over some of the key terms that you'll see in the RCCE space. So social and behavior change, or SBC, is the use of diverse approaches to support change in knowledge, attitudes, beliefs, and norms and behaviors by addressing barriers to desired change at the individual, interpersonal, community, service, and structural levels. This can be done in all contexts, but can also be referred to SBC in emergencies in humanitarian settings. Community feedback is about listening to the voices of diverse groups and individuals within a community in order to identify opportunities, issues, and needs as they relate to any type of programming, initiative, or context. Community engagement, again, all context, is working with and through community groups to achieve long-term and sustainable outcomes, processes, relationships, decision-making, and/or implementation in these spaces. Rumor tracking is a community-based approach to gather and address information gaps and misinformation, and is a critical part of RCCE. It goes hand in hand with social listening, which is similar and complementary. However, it focuses on monitoring messaging, discourse, and narratives on social media platforms. So together with rumor tracking, it can be used to monitor infodemics, which occur when there is a proliferation of false or misleading information that is spread by people in digital and physical environments. So why child-centered RCCE? If communities are key stakeholders and partners in the response, as they should be with RCCE, we ensure that what we do is based on their realities, evolving needs and capacities for a higher quality and more effective response. Children, as we know, are part of every community affected by disease outbreaks, but are often not prioritized as key audiences and partners in the response. However, there are a number of reasons why we cannot afford to leave children behind when it comes to RCCE and the response more broadly. First, children have the right to information and participation, both of which can be met by prioritizing a child-centered approach to RCCE, making sure they have the information and activities tailored to them that support their engagement. Children experience the world differently than adults, which means they will also experience outbreaks differently, given their unique perspectives, networks, knowledge, access, and abilities. This demands a unique RCCE approach to support them in navigating the context of their outbreak. Children also represent a significant proportion of the population we are working with. For example, in Uganda, the location of the most recent Ebola outbreak, children accounted for 52% of the population. Children have power and are powerful. They can be effective change agents in their networks, and they can support the response. Lastly, there can be a positive and protective influence on children's mental health and well-being if they are able to be active participants in the response and support the development of their self-efficacy and agency. I will now hand over to Nidhi for a small activity.
Thank you, Steph. So before we begin the next part of our webinar, let's take a moment to share some lessons learned using this short activity. The question I'd like us all to answer is, what is one major lesson you've learned during previous efforts to undertake child-centered RCCE during an outbreak? So this can be any type of infectious disease outbreak that you might have experienced in your context. So can I ask each of you to take a moment to think and type your response in the chat box, but please don't press send yet. We'll give everyone about a minute to think of a response and type it in. So please hold off pressing send, just prepare your response in the chat box, and I'll give everyone a minute now to do that. And then we'll all press send at the same time. So the question once again is, what is one major lesson you've learned during previous efforts to undertake child-centered RCCE during an outbreak in your context? So type in your response into the chat. All right, that should be about enough time. So I'll invite everyone to press send at the same time. 3, 2, 1, press send, go ahead. And as those responses come in, let's move on to the next slide, giving everyone a chance to share their ideas. Thank you. So as those come in, thank you, everyone. Let's move on to our next slide, which captures key considerations for child-centered RCCE. While we can't cover everything in detail today, Steph and I wanted to make sure that we at least offer an overview of some of the principal areas where RCCE can be more tailored towards the needs of children and their caregivers. And we can already see from some of the lessons learned in the chat by audience members that there's a lot to think about. So one aspect to consider is age and life stage. So children are not a homogeneous group. We need to understand the key subgroups within children. So for example, married girls, children in displacement, children in detention, unaccompanied children, etc. Children of different ages also have different information needs based on their development, evolving capacities, and life stage. Adolescents, for example, may wish to understand how an outbreak impacts on their sexual and reproductive health. All children will need to know about their rights and how to keep themselves and their loved ones safe from getting sick or safe from the indirect harm created during outbreaks, such as increased sexual exploitation and abuse, for example. Children of all ages will need to understand how to report and refer child protection or safeguarding concerns during an outbreak. Gender is another key consideration. Primary caregivers of children are often women. Of course, that depends on the context. For example, in Democratic Republic of Congo, 1/3 of adult women cannot read. So this makes verbal and visual communication very important. In many settings, adolescent boys and men are the ones who are more likely to have access to radio and other devices than their female counterparts. So this should be considered when designing communication materials and dissemination platforms. Disability is another aspect that must be considered. In many settings, the World Health Organization estimates that at least 15% of the population, and often more in humanitarian contexts, will have some kind of disability. This can range from physical, mental, intellectual, sensorial disabilities to chronic conditions and more. Some of these disabilities will be invisible. They nonetheless need to be catered for in RCC materials and targeting. Otherwise, we risk excluding a large cohort of the population, including both children and caregivers, that may already be more marginalized. We actually have a great example from Malawi of how RCCE can be disability friendly. So before Steph comes back on with more key considerations, let's share a short jingle that was developed as part of the recent response to cholera in the country.
Kololini tisambe manja tawi zonse ochoka kuchimbuzi komanso sanage tisambe manja somba mteja tawi zonse komanso tikasinta chewera la mwana tisambe manja somba ya mwe mwana tikale au kondo tipewe kolera
Thank you for sharing that amazing example. I hope it was a good opportunity for everyone to practice their Chichewa. And in the same vein, wanted to talk a little bit about language. So depending on the context, it may be necessary to identify which language or set of languages should be used for communication. Some settings, like DRC, are incredibly linguistically diverse, and additional effort needs to be taken to ensure key terms and messages can be effectively translated and understood. This may need to be hyper-localized to serve the needs of different communities within a setting, for example, Indigenous and refugee populations, without discrimination. Children especially may be more familiar with their local language or dialect rather than the official national language. Child-friendly versions of key concepts will also need to be developed. This can be done in collaboration with children to move away from technical jargon to terms which are more commonly used and understood. Regardless of the materials, they should always be pre-tested for comprehension and to avoid misconception prior to dissemination. With regards to timing, channels, and formats, it's important to understand what channels and formats children and their caregivers already receive information through or prefer to see the information through. Consider which services and spaces children and caregivers are still accessing during the outbreak. For example, this might be schools, pharmacies, markets, health centers, and use these venues to display posters or provide interpersonal communication. Access to the information will also depend on communication channel choice, especially in areas with poor communication infrastructure. Lack of access to telephones and network coverage can complicate access to helplines and hotlines, and many community members may prefer face-to-face communication and audiovisual formats. Children and adolescents may use different platforms than adults, including social media and peer networks, and they may also access information at different times of the day, week, or even month. And this can change during school holidays or outbreak-related closures, for example. Face-to-face communication may be done by community volunteers, other non-medical personnel, and peers, so they need to be supported by response partners on how to convey complex medical terminology, concepts, and address questions and concerns. For example, so they can redress rumors and misconceptions, demystify care pathways, and overcome vaccine hesitancy. Where possible, it's good to design communication formats that will be most engaging for children. So think about using games, songs, dance, and dramas to convey your information. Children's unique needs and risks can also be addressed through targeted messaging for caregivers, for example, to promote positive parenting, home care, and safe schooling. For child participation and community consultations, we can't develop and deploy an effective RCCE strategy without consulting children on their specific needs, communication and engagement preferences, understanding of the disease outbreak, and the response. Prioritizing this at the preparedness or onset stage is critical, however, should continue throughout the response to have open channels for child feedback and engagement. Care needs to be taken during the consultation and participatory activities to make sure that they are ethical and do not cause any harm. It is best to work through existing children's groups and networks, and where possible, in collaboration with other response actors to make sure that we're minimizing the burden on these groups. For consultations to be meaningful, we need to be intentional about closing the feedback loop with children so that they can truly see the results of their participation. Lastly, there may be some existing social norms around child participation in the community, response actors, or even governance structures. Being aware of these norms will increase our ability to work within them and support the amplification of children's voices in the response in a safe and responsible way. Lastly, information accuracy. Any information that we share should be accurate and based on the World Health Organization's guidance, from the government guidance, or other trusted sources. In addition to being accurate, we want to be timely and relevant. So if there's a gap that exists between the information needs of children and the information we are providing, this opens the door for misinformation, rumors, and distrust. Adapting our RCCE strategy based on what we're hearing through feedback channels for children and communities assists in closing this gap. Now we've gone over quite a lot of theory, so it's time to see what RCCE looks like in reality. I will now hand over to my colleague Rui Mutemba, Save the Children Mozambique's communication coordinator, to take us through a case study.
Thank you very much. I hope everyone is feeling well today. So what I'll do is to share with you all some of our experience we have gone through when we had cases of COVID-19 back in 2020. So in Mozambique, the first case of COVID-19 was reported in late March. And what we saw is that every sectors almost just rushed to develop campaigns to let people aware of the disease and the prevention measure that could be taken. But we sadly noticed at the same time that those messages, those awareness campaigns that were being developed were not quite well informed, specifically for children. So that's how we rushed it to gather some local partners to develop a national campaign that would specifically address issues affecting children, how children were to be informed on specific measures to prevent against the COVID. Fasik, pass please. Pass the slide. Yeah. So as I was saying, what drove us to develop this campaign was in fact the fact that there were no child-focused message, no message for children to children, and the whole scenario of campaigns that were being run were not practical in terms of what the specific measures should be taken. So before we held on designing the campaign, we need to get specific information that could inform on how this could be done. So we just ran a rapid community risk assessment through household surveys, and we wanted mainly to identify the gaps, especially specifically among children or households that had children, and focus on what their parents and caregivers thought about the message that they were already running regarding what the disease is and how to prevent it. So please pass. We just ran this campaign through almost 800 households, and we found out that almost the adult population had a very quite good information of what the disease was and which were the main groups that were being affected. But at the same time, we noticed that in locations that are affected by conflict, for example, in northern Mozambique, in the province of Cabo Delgado, this knowledge was lower, which at the same time told us that this means that children are more at risk of being more affected by the disease. So compared to the rest of the country, we had like 90% of adults who were saying that they were aware of the disease, but in the conflict affected areas, this number dropped to almost 64%, which was very concerning to us because that informed us that if the adults do not have information, the scenario was likely very worst regarding to children. So in other provinces, like in central Mozambique, the number was quite low compared to the south, where people have more access to information. So we felt that we really needed to develop something that could target all the children, regardless of their location. Please pass. Yeah, so that's when, based on the information we got from the RCCE work that we developed in terms of assessment, we came up with the idea of bringing something that could really attract the attention of children, focusing on their behavior. So we worked with an IT company that helped us to produce two animated characters. We call them Zinha and Paito and Zinha. And we developed three videos, animated videos that had specific message in terms of raising awareness on main preventive measures to stimulate self-care, increase awareness in terms of knowledge and self-efficacy on what to do in case of symptoms or infection. And those three videos were ran through TV stations in Mozambique for almost 3 months on a daily basis, which was quite expensive to us, but it's something that we felt that needed to be done in order to make sure that the children and their parents and caregivers were well informed and were not left behind in terms of knowing the disease, how it transmits, and how to prevent it. Can you go to the next slide, please? Yeah. So what we did in terms of composing the message that they were delivered through this message based for those channels and based on our findings on the assessment. We just had a very multi-sectoral team that they developed the key message, including children as well. We worked with children from the child parliament in Mozambique, which helped us to develop a message that were specifically addressed, and we making sure that those messages would meet what children needed to know and do towards the diseases. So beside the team that was set up internally, we also worked with a creative team from the IT companies, and that's how we came up with the with these 3 videos made mainly by the 2 characters, Zinha and Paito, and it came out that please go to next slide. We had a very good success, and some of the messages that I mean, not some, but all the messages that were being passed through the videos were also converted into radio message that also passed through community radios. And at the end, we found out that we were able to reach almost 8 million people during the 3 months we broadcasted those messages, those videos via TV and also community radios. We reached 8 million people. We also capitalize the social media availability. So we ran also those videos and message through social media like Facebook and the Twitter, which helped us to spread more the message, specifically for those children that are mainly in the cities with access to internet, and they were able to connect and have access to this important piece of information. So in terms of main challenges and learnings we had throughout the process is that to develop a very consistent RCC campaign that is really meaningful and impactful, it's important that you set up timely, a key functioning and vibrant multi-sectoral team that understands what is being done. But we face some challenges like the availability of funds and making a follow-up, the complete cycle of RCCE. But at the end of the day, as I mentioned before, we were very happy to know that we contributed to prevent that the children were amongst the most affected group in terms of infections in the country. And I don't know, do we have another slide? but I think this was the last one. So basically, this is how we did our work, and this helped us to make the country as the few of the few impact one of the countries that they had a very less impact in terms of COVID problem in the world, specifically for children. So I will stop here and say thank you. I'll share here on the chat box the links just in case someone has interest seeing what actually those videos were and what kind of message were being passed through the videos. For those who don't speak, the original language of the video is Portuguese, but they have subtitles in English. So I think it will be good for all to see and understand what we are saying. Thank you.
Thanks so much, Rui. We'd love to see those videos. So yeah, please post them. I see you've posted them in the chat already. So next we have our colleague Magnot up next to talk about Ebola and COVID-19 in Uganda. Over to you, Magnot.
Hello, how are you everyone? So just a bit of context that on 20th September last year is when we had an outbreak of Ebola in Mubende district, but cases were escalated into several districts, including Wakiso. Wakiso seems to be a very busy district. The capital city is just inside the district. It's almost like the capital city is an island within the district. So most roads to get to the city, you have to move through the district, which is a very busy district with quite a number of schools in the country, almost 1,000 schools, both primary and secondary are in the district with quite a number of learners. So just for you to appreciate the context and setting. So we are concerned, just like my former speaker, most big, is that one of the areas where we are not concerned is the messaging to children. But when we are hit with these particular pandemics and outbreaks, we had scenarios of the Ministry of Education and Sports contacting Ministry of Health to share information. And most cases, we find that this information that is shared does not look at learners particularly, and sometimes it's for the broader community. So what we use usually is what we call, we came up with school task forces, and these school task forces include the school health clubs. They have learners, probably around 10 to 15, but they're representing the various classes. And specifically, I'm speaking about the primary level, where we have most of our interventions. So they have various representatives from these particular areas with the sanitary prefect as the chair, and then a school health patron, who usually is a senior man or senior woman teacher in these schools, and they oversee the activities of these particular areas. So we have child-friendly messages that are disseminated by the school health club members to fellow learners, and usually trainings are done for these particular different school health clubs or school task forces who understand the message, and then they share the messages in the various classes. They also utilize existing linkages and structures. For instance, youth champions. The youth champions are centered at the neighboring health center. The health centers that provide services to catchment areas, including schools, which are viewed as communities. So youth champions are trained on aspects to do with adolescent sexual reproductive health, and they share information on water, sanitation, and hygiene. So Witala is part of this to work together with the school health clubs. They look like role models for these particular learners, but usually they are in the upper section of primary 7, primary 6, about 14 or 15 or 13 years, between that range. And then village health teams. The village health teams is a recognized community structure within our structure of government or health. and their role is to move door to door or within community and ensure that people receive services. Sometimes they do RDTs for malaria, but in this context is that they share information to do with any outbreaks, also report these cases to the nearby centers. So during school closures, we were able to work with these particular structures to ensure that information reaches the community, together with the school health clubs, and in context where we had school closures. So they were very pertinent in the spread of information. You can imagine where a number of schools are closed and yet information is required. And so you need also to know that schools are not just institutions of learning, but they provide information to learners to ensure that they receive access to services and anything to do with school health. So we utilize these particular structures. And then also the youth champions supported us in the supervision of health services, but all these are supervised by a health assistant. The health assistant is attached to the health facility, and one of their cardinal roles is to ensure that they look at the public health component, the environment health, and any other outbreaks within the community. They ensure that there is public awareness of services, but also supervise the VHTs together with the youth champions. And so one of the other demonstrations we got from the school health clubs is hand washing, where they're responsible also to develop low-tech hand washing facilities like tippy taps, both in the school and in the community. So they move and work with the local chairpersons, those particular villages, and they establish them, for instance, near marketplaces, near gatherings, churches, where people would meet, open near areas where there are village meetings. So this is one of the areas where really they supported us. Tippy tap is made out of a jerry can and the thread, and water is put in. And you can imagine that schools battled some of the this equipment, sophisticated. So what was available and easy for us to prevent this spread of both COVID and Ebola for the tippy taps. And then the school health parades. The school health parades, usually school health club members demonstrate hand washing moments. Like for instance, the image you see on the left, they show how using the WHO standard, how exactly do you wash your hands, which areas do you clean, how many times do you clean, what are the critical areas of hand washing, after the latrine, before eating meals, after playtime. These are some of the, like, so learners learn from fellow learners when they're sharing this information. And sometimes in most cases, it's also done in the local language, such that the lower classes can also pick up from that. And then we have drama and skits. These are done both at school and within the community. And the school health patron really plays a cardinal role to support learners in this particular area, to be able to come up with the themes, the different plays, the message they want to share with the community. So the children works together with this particular group to ensure that the key information comes out in one of these areas. And communities love skits, they love drama, and there is information that comes out. So among the challenges that we have experienced, one of them is limited resources. Schools were supported to be able to make soap making, but one of the areas they suffer with is the prices went up for the materials for soap, inadequate water access and availability. For instance, also materials for making face masks. These were challenges that schools faced to be able to produce them at scale or for larger communities. And also the issue of attitude of learners, face masks, proper school structures, and then the difficulty in implementing some of the government operating procedures, the high number of learners within the school. These are some of the challenges that we faced. Over to you. So,
thanks so much, Magda. Very interesting. Yeah, thanks so much. So we have about 15 minutes left, roughly. So we're going to go into the question and answer section of the webinar. So if I can ask all of our panelists to pop their videos back on, and we'll try and answer some of the questions. So I see one question here in the chat, which says, what should be the approach of, I think this is risk communication, community engagement between local organisations, international, local government authorities, I imagine that is, and the government in general, because sometimes INGOs don't involve local organisations. So this is a question and a reflection, I think. So I will maybe just put that towards Steph first, and see if you have any reflections from that question. Thank you.
Sure, thanks, Sarah, and thanks for the question. I think it's an important point to reflect on. I mean, when we're talking about RCCE and response in general, it's communities are our first responders, right? And local organizations are often our first responders. So it is critical that we're coordinating with them. Often what we'll see is a very top-down approach from governments on the coordination mechanism, and they will be bringing in NGOs, local NGOs as they see fit to participate in the various coordination meetings and technical working groups. I think for us as NGO actors, it's really important that we advocate to ensure that there's space at the table for local organizations, but also make sure that as we are going through our work through RCCE, that we're enabling, activating our network of local partners that we're working with. And for me, I think the biggest justification for working with them, I mean, throughout this webinar, we've talked about the importance of centering kids and communities, and they can provide such deep, meaningful insights of what the context is, what the needs are, and they can help us deliver a more context-appropriate RCCE approach. So yes, just something to keep in mind, although it sounds like we've got it already, but just that engagement of formal and informal community groups is critical.
Thanks, Steph. And it makes me think a lot about child participation, because of course these groups are often, you know, they're local organisations, they are part of government structures, schools, etc. So Henk, I'm going to direct this one at you, and ask you to provide some kind of top tips from a child participation point of view in the development of these risk communication, community engagement strategies and materials. So if you're an audience member listening now, where should they start in involving children in the RCCE process?
Okay, thanks, Sarah. Can you hear me?
Can hear you well, yeah.
Okay, good, great. Well, I think it was already referred to in the different presentations we had today from Uganda and Mozambique. It's actually very important to reach out and to engage with existing children's groups. We talked about, you know, just now about linking up with local national organizations, but it's actually really very important. So make sure that you reach out to existing children's groups, either through our own work. I mean, if you're already engaged in the communities through whatever type of work we are doing, we can, and it doesn't have to be in the specific area of work we are looking at. I mean, if we have a health program, and you know, if we work with health clubs or whatever, or if it's an education program, it doesn't matter. It doesn't have to be related to health or anything. Just look at what kind of programs are ongoing and with existing groups, and very much also through local organizations, whether they are local groups or whether it's our partner organizations who are working with those children's groups. That's actually most important, because that engagement is already there, that connection and that relation is already there. Another very important aspect is that involve those children and groups so as much as possible in needs assessment to get a sense of what is important from their perspective, and have to be involved in the design and phrasing of the RCCE materials. And then you can also involve them in pilot testing any communications with them. And then, of course, they can also assist you in the rollout and even in the right language. And the right language, I mean, just not the local used language, but also the wording and the jargon and how people are communicating with each other. And then another important aspect, I think, or tip is like that before the outbreak, it's important to involve, you know, before even there is an outbreak, that we work with local partners and children's groups to anticipate any type of outbreak that may happen. Like this, you also talk about disaster risk reduction, but then to develop strategies and plans with those groups, with the local groups, and so that you are prepared and ready to jump into action when an outbreak happens. These are for me the most important top tips, so to speak.
Thank you, Henk. They are very good top tips. I think having responded to a lot of outbreaks before, and now obviously everyone's experience with the COVID-19 pandemic and movement restrictions, a lot of our existing structures and ability just to move around and to reach these groups are hindered. So I'd like to ask Rui, I think, because you touched on a few aspects of like new innovations and this video. So I just wondered if you could tell the audience a little bit about, if there are lockdowns, movement restrictions on large gatherings. Have you seen some successful ways to overcome these challenges in outbreaks and to continue child-centered RCCE? You're on mute.
Yes, I think that's what we also during the pandemic. Movements of people were very restricted, and you could not, for example, run normal campaigns where you have gatherings of people, for example, mobile brigades where you gather people and they pass a specific message. That's why we thought it was important in our case to use means like TV, social media, or even community reach, which is something that is capable of reaching people whenever they are in their inner houses. So it's something that really showed us like working rather than using traditional means of communication for change that we have been witnessed and applied before. So I mean, those means that they are capable of reaching people inside their home, maybe a better approach in those scenarios.
Thanks, Rui. And then Magno, I think you probably have some examples as well, having just experienced the Ebola outbreak. Do you have any examples of innovations to overcome these difficulties that are so often present in outbreaks?
Thank you, Sarah. I think one of the challenges you have is the normal campaigns and how do you reach people. But particularly one of the innovations we looked at was the available structures and how flexible they were, and also looking at how would we integrate the available standard operating procedures to ensure that people receive information. So when you look at the VHT structure, they were listed among essential health workers, essential staff, together with health workers. So we would use health assistants who usually move from community to community. So one of the things they will do is share the particular information with VHTs. So VHTs go and mobilize door to door because particular VHTs are attached to particular villages. They don't overlap in other villages. So there they are sharing information, but also they work with youth champions who reach out to children and they understand the child-centered language. So children are able to receive information from those various platforms. The other avenues include caravan drives, where a particular vehicle with particular information moves from community to community, sharing that information, while certain music is being played that interests people, so it gets them to hear the information. So that's exactly the modality that supported us during, total lockdowns. Other issues, other information and messaging is a bit limited power setting because most communities don't have access to televisions, maybe radio stations, and that's where they get information, unlike the town centers where information is over to you.
Thanks, Magno. Great. And then I'm seeing another question in the Q&A function around community-based surveillance and child protection and health. So I'm hoping I'm interpreting this question right, but it's something we've talked about before, about integrating child protection into kind of communities systems, and we know that during outbreaks there's community-based surveillance happening on quite large scales, sometimes contact tracing, etc. And I think we've discussed even amongst the panelists here about how we can use RCCE to address some of the increased child protection risks that we see in outbreaks, not only about the kind of disease transmission itself. So I'm going to direct this one towards Nidhi and ask you, how can we use RCCE to address the increased child protection risks that we know are more present during outbreaks?
Thanks, Sarah. Yeah, I think that that's the point in itself, is that RCCE can be about communicating risks related to infection, but it can also be about communicating risks related to the outbreak itself. So the indirect impacts and risks faced by children and their caregivers as a result of the outbreak. So that can look like increases in child labor, forced recruitment into armed forces, sexual exploitation and abuse, a whole range of different types of child protection risks that we may encounter in a given context because of a large-scale outbreak. So RCCE messaging needs to not focus only on disease-related messaging, but also on these increases in child protection risks, which can be, you know, equally devastating for children and their communities. So, you know, we saw, for example, in the COVID outbreak that the infection rates and fatality rates amongst children may be lower, but the impact on children was no less grave. In Ebola, we have the reverse, where, you know, the fatality rate amongst children is much, much, much higher than COVID. So we need to vary our approach according to the type of outbreak, but not forgetting that any outbreak will bring a host of child protection risks along with it. So I think it's important that we ensure that RCCE is not just purely related to infection and disease transmission and messages related to that. Yeah, but I'll open it up to Steph or to Henk if they want to add any more elements to my response. Thank you.
Nidhi, you're saving me from typing here. I was just going to say that, I mean, completely agree with your response there. But also let's not limit our inclusion of child protection issues and those kind of secondary or distal or indirect impacts on kids just to our communication. There is definitely scope to include those in our community engagement activities. So sitting down with those community groups and working with them to identify what they think the indirect risks might be of a disease outbreak, and using that opportunity to also think about some of the actions that they can take as a community to mitigate and hopefully eliminate those risks. Henk, over to you if you have anything to add.
No, I just wanted to say protection is not possible without participation. I mean, it's so crucial, and it's actually referring to what Sarah started the webinar with. Children need information. It's so crucial for their own protection, and so you also saw from the COVID research, and I really, if you have not seen that research, that you have a look at it. It's like the correlation between children who don't have the information and their levels of anxiety and worries and so on. So it's actually very important to make sure that children have the information, and it will help them to be better protected. It's really very, very crucial.
Great. So unfortunately, that's all we have time for, and these hours always go by very quickly. I think we're probably going to have to, well, I'm going to use this last 30 seconds to ask this poll question. So we at Ready would like to know what else we can do to support your organisation to be able to undertake and support child-centred RCCE. So I'm going to ask you to quickly select what you feel you need as individuals and organisations. I can see some results coming in now. Thank you very much, everyone. I know we're right in the last minute. Great, so maybe we'll end that poll now. Right, so I see a big big ask for face-to-face training. This is not unusual. More training and e-learning, operational guidance, practical tools, so essentially everything. So we'll take that into account in our activities. But for now, I'd just like to quickly close and thank all of our participants, presenters and panelists, and just point you in the direction of our Ready resource library, where we have multi-sectoral tools and guidance for outbreak readiness. We also have a learning hub at Ready, which has got more than 60 courses curated from not just Ready, but WHO, UNICEF, and over all the different sectors that play a part in outbreak preparedness and response. And we also have some outbreak simulations on that. But for now, I'd just like to say thanks again to everyone. Thanks to our brilliant interpreters, and special thanks to BHA, our donor, and of course our colleagues from Mozambique and Uganda. Thanks so much for sharing your experiences with us. And thanks to the audience for your participation as well. So thanks everyone. Good morning, good afternoon, good evening, wherever you are. And we'll send the recording of this out and a follow-up email, so you'll have these materials as well. Thanks for joining us. Bye.